why not I talk something about practical exams related to peritoneal dialysis. So my focus today is all related to that only. Okay, so as this is not a lecture, I would request any of you to stop me any moment of time, interrupt me, ask questions, clarify it then and there so that we can proceed. So what I have focused is totally exam based. So let's see what is here, which I could prepare in last 4 days. So what are the situations where peritoneal dialysis can be discussed in exam? One is you may get a case related to peritoneal dialysis, or you may get a table viva where peritoneal dialysis things are put in and you may be asked to pick up one of those. So we'll discuss briefly whatever time permits and what I can recall from my memory about these two situations. So about cases, so what kind of cases you can get related to peritoneal dialysis? One, you can get a stable peritoneal dialysis patient. So there are not many active cases present, so they pick up a peritoneal dialysis patient who had come for follow-up or for any tests and put them on the bed and ask you to examine the PD patient. That is one scenario. The other scenario, little less likely though, is infective complications. So infective complications, so you should know that peritoneal dialysis, when you are asked about complications of peritoneal dialysis, you should divide them into infective and non-infective complications. And infective complications, one is PD-related peritonitis and others are exit site and or tunnel infections. So they can put in patients who might be resolving. They may not put in very sick patients for examination, but there might be patients related to PD-related peritonitis or exit and tunnel infections. In non-infective complications, there are many non-infective complications. Don't go by my tables right now because these are only related to discussions in the exam. So non-infective complications like metabolic complications I have not mentioned. So there are many more complications, dyselectrolytemia, etc., etc. But what they can keep is a patient who is under-dialyzed. So he's on peritoneal dialysis. He has all the symptoms related to uremia, and you may have to discuss what you can do for under-dialysis. We will briefly discuss all those. You can have a patient who has got a poor flow, poor catheter flow, either inflow, outflow, or both. And then there may be a patient who has got shortness of breath in a PD setting. And one of the differential you should never forget is hydrothorax, which is pleuroperitoneal communication or shunt. And the other one is a rare but fatal complication of peritoneal dialysis, which is encapsulating peritoneal sclerosis, which is EPS. So let's see some of these we will discuss briefly. And if I miss on any one of these, remind me, we can go back and discuss briefly those. So why it is not moving forward. And what about table viva? So table viva, what things they can keep depending upon the center where you get your exam is they can keep an APD machine itself. They can keep APD cassette. I've seen people faltering with APD cassette. There might be PD catheters. So PD catheter may be acute stiff catheter. There might be a cuffed 10-cuff catheter. There might be small consumables like Minicaps or titanium adapters or transfer set, which you should be able to identify. And I'll give you photographs of these while discussing the entire talk today. So let's begin from stable patient. So those were two scenarios, cases and table vivas. So one by one, we will briefly try to touch most of them. Stable PD patients. So types of peritoneal dialysis, you should know what are different types of people. Usually in exams start with very simple questions, which are believed to be known to everyone, and then slowly they build up and go into complications or advanced questions. So some basic questions you should remember, which should not be filtered right in the beginning. It gives a nervousness as well. So types of peritoneal dialysis we will talk about. Adequacy, what is adequate dialysis? You should know that. PET test, peritoneal equilibration test, when to do, how to do, types of membranes, and types of PET test as well. So there are two different types of PET test. We will talk about that. How to initiate a peritoneal dialysis in a patient. So some of these questions I would like to answer right here because I do not have details. So how to initiate? So if a patient comes, a naive patient comes for peritoneal dialysis. So what you look at initially is what is the general condition of a patient? How uremic he is, number one. Number 2, what is his fluid status? Number 3, what is his urine output? Number 4, also we consider is whether he's a proteinuric CKD or a non-proteinuric CKD. You have to, and all these may help into different other cases as well. So by proteinuric CKD, we expect that patient will have more of an edema, less of a urine output, as against non-proteinuric CKD, where urine output is still maintained for a longer period of time and edema is less likely or less as compared to proteinuric illness. And that is how you will decide the strength of bag and duration of treatment. Ideally speaking, the advantage of peritoneal dialysis is a 24/7, as against hemodialysis, which is 3 times, conventional hemodialysis is 3 times a week. And that is why it says that the physiology goes yo-yo. There is a yo-yo phenomenon in physiology. So immediately after hemodialysis, the urea creatinines are rock bottom, and over next 2 days it goes again to a high level, and then again you bring it down with hemodialysis, which is called yo-yo phenomenon, which is not seen in more physiological peritoneal dialysis because it's 24/7. But many times what we do is we do not initiate PD patients on 24-hour cycle. And that is to give some kind of a comfort and relaxation and the concept of incremental dialysis as well, which you should know. So what we do is when somebody is on CAPD, continuous ambulatory peritoneal dialysis, we give them a night dry. So they do an exchange, 3 or 4, whatever you decide. During daytime only, nighttime is dry. So stomach, belly is dry in the nighttime. So practically they get dialysis for 12 to 14 hours only, right? And as you make an assessment that no, they require more dialysis, you can switch over these patients into 24-hour cycles, right? So in APD patients, if you initiate somebody on APD, then what you do is you give all the cycles during night. You do not use the last fill. Last fill usually carries on during the entire day. So when you are asked how to initiate, you put all these questions into consideration, and roughly you start with, for example, 2.5% bags, 3 exchanges, night dry. And you ask the patient to come back in 5 to 7 days time for reassessment. And during reassessment, you look at the uremic symptoms, you look at the fluid status. And if there are uremic symptoms, that means you need to increase the dialysis dose. And when there is fluid overload or fluid getting retained, then what you need to do is increase the concentration of the bags. So you have to understand the difference between fluid and the uremic symptoms. So that is how you initiate, and then follow up with labs, etc. So this was briefly how you initiate. How would you select APDs, or when would you select APD? So somebody can ask, when would you select APD? So number 1 is you offer CAPD, APD to all patients. It is the choice of the patient whether they want to go for APD and versus CAPD. Overall, I should tell you the outcome of CAPD versus APD, there is not dramatic difference. There is not great outcome changes. So mortality or even peritonitis rate, etc., is similar between CAPD and APD. So outcome will not determine or guide you towards the treatment between CAPD versus APD. So number 1 choice is, number 1 reason for choosing APD is a patient's choice. Number 2 is in high transporters where we'll talk about PET, but in high transporters where you desire a smaller dwell time, APD is beneficial because it automatically gives a dwell time of 2.5 hours, 3 hours, etc. For CAPD, you cannot ask patients to do a exchange every 3 hourly. It will become very cumbersome. So that is the second reason where you choose APD. Number 3 reason for choosing APD or not choosing APD is the financial status as well, because APD is almost twice as expensive as CAPD. 3 exchange versus APD 10 liters. So these are some reasons when would you select APD. What are different strength bags available? Sometimes people miss out on these kind of simple questions as well. What are the different strengths of CAPD bags available? So in India, we used to have 1.5, 2.5 and 4.25 bags, but unfortunately 4.25 bags are not available. These are dextrose based bags. And the other one is icodextrin, which is 7.5%, but 7.5% is not dextrose. You have to understand, okay? It's icodextrin. So right now, there are 1.5, 2.5 and 7.5% bags are available. 4.25 used to be available, but now it's not available. Sometimes theoretically they may ask on table viva or while discussion, what is sodium sieving? In last my PD class, I did explain in detail. Briefly, I would mention that sodium sieving doesn't occur in icodextrin. It only occurs in dextrose-based dialysate. Why is that? Because when you put in dextrose, there is immediate switch on of the ultra small pores. So there are 3 different pores as per the pore physiology in PD literature: ultra small, small, and large pores. Ultra small pores basically are aquaporin channels. So aquaporin channels only allows water transfer. So for coefficient reason, which is a long discussion, I'm not going into detail, icodextrin doesn't stimulate ultra small pores. Okay, only dextrose stimulates ultra small pores, that is aquaporin channels. So what happens is when you put in dextrose based dialysate, there is sudden opening of these aquaporin channels and water rushes from the vessels into the peritoneal cavity. Right, that is how you achieve ultrafiltration. The aftermath of this is what happens is, because it is only water channels, sodium is not filtered initially in first hour unless the small channels open up and that equilibrates. So in first hour, sodium is retained, and hence you may see a mild hypernatremia in the blood and hypotonic or low sodium in the dialysate. So dialysate does contain sodium, but if you take out the dialysate at 1 hour, supposing the dialysate sodium was 137, after 1 hour it may be below 135. Why? Because water has entered and diluted it. And this is what is called sodium sieving. And how does it help? What is the conclusion of this? Conclusion is the efficiency of aquaporin channels. So if sodium sieving is there, that means if the dialysate sodium drops below the original dialysate sodium level, that means aquaporin channels are working fine. If it doesn't drop, that means aquaporin channels, because of maybe peritoneal fibrosis, are all disrupted, it is not working. And that may lead to ultrafiltration failure, which we will subsequently discuss. Okay, so sodium sieving, you have to understand. This is an important question sometimes people do ask. So let's talk about what are different types of peritoneal dialysis. So peritoneal dialysis can be acute intermittent peritoneal dialysis, which we normally do by stiff catheter, but nowadays bedside Tenkov catheter can also be inserted, and that is done in acute stages where there are 1 to 2 liter exchanges. So you can put in 1 liter or 2 liters depending upon the size of the patient, and that can be continued 16 to 20 hours. Clearance is low, but it takes over the tide and patient stabilizes. It can be continued for longer period of time, but acute intermittent PD catheter, especially with stiff catheter, have high risk of PD peritonitis, and it increases every hour after 48 hours or every day after 48 hours. What is tidal peritoneal dialysis? What you do is initially you instill 3 liters and then followed by 1 to 1.5 liters or 2 liters keep in and out. So you let some amount of fluid to remain in the belly all the time. The concept is when you do a CAPD or APD, the conventional one, the fluid goes in and the entire fluid comes out, and then again you refill the belly with new dialysis solution. What happens is during the removal of fluid and entry of fluid into the belly, there is some time where peritoneal membrane is not sufficiently in contact with fluid, so no transfer occurs, so we miss out on that time, right? So effectively, if you are doing 24 hours, maybe 4 to 6 hours we might be wasted not doing peritoneal dialysis because fluid is not in contact with peritoneal membrane. And that is how tidal PD came into being, where 1 to 1.5 liters is in contact with peritoneal membrane for the exchange all the time. That is tidal PD. So this is utilized in hypercatabolic patients, PD patients in ICU, etc. Continuous flow PD is another form of peritoneal dialysis where there are 2 axes. So one is for instillation and one for exit of the peritoneal solution. So it is usually suggested to have 300 mils per minute of continuous flow. So for continuous flow, you need 2 axes, or 2 PD catheters have to be instilled. Again, for hypercatabolic patients or in ICU, you can utilize this. High volume peritoneal dialysis is where you use very high volume. It is a continuous therapy. There are frequent exchanges. So 1 hourly exchange, you can do 1 to 2 hourly exchange. And usually it is impractical to do it manually. So cycler is used and the volume goes up to 36 to 70 liters, as against here, you see, if you use 1 to 2 liters, it may be 20 to 40 liters. Here it is 36 to 70 liters, right? So acute intermittent versus high volume is volume difference. And then continuous equilibrated peritoneal dialysis. You have to understand, for equilibration, the solution has to remain in contact with peritoneal membrane for at least 4 to 6 hours. And if you do a rapid exchanges of 1 hour, 2 hours, then probably you have not utilized fully the exchange. But then you need it for different reasons. For example, for fluid removal and the very small solutes like potassium removal, etc., etc. So in this continuous equilibrated peritoneal dialysis, you keep the fluid for longer hours, for example, 2 to 6 hours, for better clearance of middle molecules. So these are different types of peritoneal dialysis: acute intermittent, tidal, continuous flow, high volume, and equilibrated peritoneal dialysis. You should remember that. Apart from obviously CAPD and APD. So I hope I'm not going very fast, but there are so many things to discuss, I have to. So adequacy, what is adequate dialysis? If I ask you what is adequate dialysis, some of you will say in peritoneal dialysis, KT over V of 1.7 is adequate dialysis. It used to be. It used to be, but nowadays, last year, there was a consensus meeting, and then in PDI, Peritoneal Dialysis International, they came out with what is adequate dialysis. We will touch base on that. How do you calculate KT over V urea? So you can calculate KTV over the adequacy either by computer generated software, or you can do it manually. I mean, it will be too harsh to ask somebody to do it manually, but then you should know how it can be done manually. And then ultrafiltration failure. So these three things let us discuss quickly. So how do you calculate manually KTV over urea? So KT is initially calculated, which is based on the same principle of UV by P, which is clearance of anything by kidneys or by dialysis, etc. And then you include the V part, the volume of distribution of urea, to calculate KT over V urea. I'll give you this by an example. So supposing a 70 kg male who is on CAPD and his 24-hour PD drain volume is 10.5 liters. So he was doing 4 exchanges of 2 liters, that means 8 liters, and rest was ultrafiltration. So total volume after 24 hours is 10.5 liters. And you calculate urea in both dialysate as well as blood to calculate UV by P. So pooled dialysate urea came out as 38, and blood urea, corresponding blood urea was 40 milligram per deciliter. So what you initially do is dialysate to plasma urea, D over P urea. So 38 by 40 comes out as 0.95. And daily peritoneal urea clearance, how do you calculate is depending upon the volume of the dialysate. So whatever the clearance is, D over P urea multiplied by total drain volume. So 0.95 multiplied by 10.5 liters drain is 9.975. For calculation sake, let us presume it is 10 liters. So 10 liters is our KT. And volume, how do you calculate volume? You can simply calculate, you can use Watson's formula, etc. But simply is 0.6 into total body weight. That means 70 into 0.6 is 42 liters. So we have already calculated 10 liters divided by V. KT divided by V. 42 is 0.238. And for understanding sake, let us presume it is 0.24. This is daily clearance. But remember, the clearance of in peritoneal dialysis is usually expressed weekly. Weekly dialysis, KT over V urea, or weekly creatinine clearance. So you multiply that by 7, and this patient's KT over V weekly is 1.68. You got it? Let's go once more. So you calculate D over P urea, multiply by total drain volume is a KT divided by volume of distribution, that is V. You get a per day KT over V, multiply by 7 is weekly KT over V. Okay. So as I said, the adequacy of dialysis roughly, if you are asked what is adequacy of peritoneal dialysis, you should say the number given KT over V is 1.7, but the newer concept is more driven by patient directed by patients. It's a goal-directed adequacy. So what does it mean? So it includes several factors. It has to be a shared decision made with the patient. It also accounts for local resources and wish of the people and their caregivers. It has a periodic assessment. It has a preserved residual kidney function. It accommodates the elderly and frail. It accounts for lower middle income countries, and accounts for children separately. So basically what it says is the decision of quantum of dialysis depends upon not only one number of clearance, but also the likes and dislikes of the patient, as well as other factors like uremic symptoms, fluid balance, residual renal function, elderly. For example, the example given by one of the professor was, for example, if somebody is a 70 years old gentleman, he doesn't have any uremic symptoms, he's playing golf 3 days in a week, and his KT over V came as 1.4, and he's already on 3 or 4 exchanges. If you ask them based on KT over V to go into 4 or 5 exchanges or add APD and add a daytime exchange, etc., he will say, what am I going to gain? He's absolutely asymptomatic and is doing whatever he wants to do. There is no reason to increase his dialysis dose so as to achieve a KT over V urea of 1.7. So it has to be a goal-directed therapy. That is what is the newer concept. And this is a table you can find out in PDI. I'm not going into detail of this. This is how prescribing peritoneal dialysis for high quality care. So potential elements to consider: volume status, anemia, bone mineral, electrolytes, nutrition, etc. And then initial and longitudinal PD prescription interventions. And the importance is shared decision making to evaluate interventions in context of priorities and establish or re-evaluate goals of care. And potential goals of care is improve survival. Obviously, it has to be. Extend time on PD therapy if possible. Increase quality of life. So if patient's quality of life gets hampered by use of 5 exchanges, then you cut down, go back to 4. Increase in life participation activities, symptom specific improvement. If patient is asymptomatic, do not increase even if KT over V is low. Reduce hospitalization, prolong residual kidney function. So if you give lots of ultrafiltration, the residual renal function is going to go away. So that is goal-directed treatment. Okay. Coming to the third part, we discussed about calculation of adequacy. What is adequacy? Ultrafiltration failure. So what is possible types of ultrafiltration failure? 3 or rather 4. Type 1 is behaves as fast transporter. So it is seen transiently during peritonitis. So what happens during peritonitis? The vascularity increases because of inflammation, and that it absorbs the glucose faster than usual. And that is what we see in fast transporter as well. Right? So this is type 1 failure. So it is transient. It may recover after treatment of peritonitis. Type 2 failure is associated with loss of aquaporin channels or its function. I already mentioned how to determine it. And this is very difficult to treat because aquaporin channels are not there. So ultrafiltration is totally dependent on smaller channels. So if that is able to take care, is fine. If it is not, then probably you may have to shift over to another modality of dialysis. Type 3 failure is loss of effective peritoneal membrane surface area due to sclerosis or adhesions. And this decreases permeability of both solutes and liquids. So there are differences between these two. Here it's liquid which is decreased. Here both solute and liquids, because the entire peritoneal membrane is probably scarred, sclerosed, or there are adhesions, and that may be because of recurrent peritonitis. So these are type 1, 2, and 3. Type 1 behaves as fast transporter, you see in peritonitis. Type 2, aquaporin channels. Type 3, peritoneal membrane surface is gone. Some also believe that type 4 failure is also there when there is increased lymphatic absorption. You have to understand that there is about less than 3 mils per minute of absorption of dialysate through lymphatic channels. So 3 mils per minute, that means 60 or rather not 3 actually, it is 2 mils, not more than 2 mils. So in 60 minutes, that means 1 hour, 120 mils of fluid may be absorbed through lymphatics. So 1 to 2 mils per minute. But if it is more than 3 mils, because of some reason, it may result into ultrafiltration failure, because whatever glucose is extracted is returned back through lymphatic channels, and that can also lead to ultrafiltration failure, which is type 4 ultrafiltration failure. So these are tabulated forms. Type 1, extremely rapid solute transport. D over P, creatinine will increase because it will behave as a faster exchange. Type 2 is loss of aquaporin channel. DP creatinine remains unchanged, but fluid will, ultrafiltration will be hampered. Type 3 is both will be decreased, as I said, and type 4 is lymphatic channels. So what is PET test? How do you do it? And when do you do it? When do you repeat it? So PET stands for Peritoneal Equilibration Test. How you do is you instill 2 liters of 2.5% dextrose dialysate with patient supine after complete drainage of long dwell. So they, even if patient is not doing night dialysis, they have to do it for the sake of PET test. So there has to be a night exchange. After night exchange, the patient comes to the hospital. You drain that exchange and put in 2 liters of 2.5% in a supine position. And you draw blood and dialysate samples immediately after infusion and repeat the samples at 2 hours and 4 hours for urea, creatinine, and glucose. And during 4 hours, patient asked the patient to roll over one side and the other side so as to expose the dialysate to peritoneal membrane. Patient is drained upright after 4 hours in sitting position and drain volume is recorded. What is modified PET? Similar to standard PET, except 2.5, you use 4.25%. So there are two types of PET. Standard PET, which is done with 2.5%, and modified PET, which is done with 4.25%. I will tell you what is the use of doing PET. So when you do a modified PET using 4.5%, you can define ultrafiltration failure if the ultrafiltration is less than 400 over 4 hours. So anyway, if you are doing PET, you have to drain it at 4 hours. So remember the rule of 4-4-4. 4.5%, 4 hours, less than 400 means ultrafiltration failure. And it correlates well with clinical behavior as well. Okay. So, okay, I do not have the tables of the PET. So PET divides the patient into 4 different categories: low transporter, low average, high average, and high transporters. High average and high transporters have fast, also called fast transporters, because it's leaky. Glucose dissipates faster in the blood so that equilibrium is set in. And after, say, about 4 hours, there won't be any exchange. And ultrafiltration will not be there after 4 to 6 hours. In fact, the reverse ultrafiltration, that means dialysate absorption may happen. In low average and low, which is also called slow transporters, the exchange is very slow. So prolonged period of ultrafiltration can still happen. And the outcome in high transporters is worse as compared to low transporters because of cardiac problems. Right? They tend to have more fluid overload, more hypertension, and more cardiovascular morbidities. And because of that, high transporters are preferred to have faster exchange, smaller dwell time, and that is why APD can be preferred. So you should remember at least this much. You can interrupt me anytime and ask questions. Open your mic and ask questions. Unmute yourself, because we may not have time to go into the chat box. I'll try to. So so we have discussed the stable patient. Coming to infective complication. How do you diagnose PDRP? What are the initial choice of antibiotics at your center? How long you have to treat in the PD peritonitis? What are the different causes of cloudy effluent? What are the reasons for catheter removal? How do you calculate peritonitis rate? So let's see how do you, initial choice of antibiotic has to cover both gram-positive and gram-negative organism. You cannot empirically treat only by gram-positive or gram-negative. So gram-positive, you have a choice. You can use vancomycin. We use vancomycin. But if cefazolin is available, and depending upon center to center, what is the sensitivity pattern in your center, you can choose gram-positive. Gram-negative is options are there. You can use either piperacillin tazobactam, you can use ceftazidime, you can use cefepime, you can use aminoglycoside. But with aminoglycoside, usually recommendation is if the patient is anuric, the definition of anuria is less than 100 ml of urine in 24 hours. If the patient is anuric, then you should use aminoglycoside, which is cheap and easy to administer. Otherwise, these are other options of gram-negative. Whenever you choose a gram-positive, gram-negative antibiotic for treatment of PD-related peritonitis, do not forget to add oral antifungals, because it has been shown that use of oral antifungals reduces the chances of fungal peritonitis in subsequent settings. Duration of treatment for staph epidermidis, it is 2 weeks. Most of the other bacteria, including Pseudomonas, Klebsiella, most of the other organisms require 3 weeks of treatment. So it depends upon the organism. You can say when you are asked how long you are going to treat. So it depends upon the organism. It may be 2 weeks, and most of the organisms are treated for 3 weeks. Okay. So definition of peritonitis is very important. This could be a first question, and you should know that. So diagnosis depends on 2 out of 3 criteria. The first of the 3 criteria is clinical presentation, which means there may be fever, abdominal pain, diarrhea, nausea, vomiting. All these are signs of peritonism. So signs of peritonitis, number 1. Number 2, PD fluid cell count should be more than 100, out of which 50% should be polys. And the third is presence of organism on gram stain or culture. So any 2 out of these 3, if present, diagnoses a PD peritonitis. Okay. So remember, I might be going a little fast, but then there are lots of things to be covered. So if there is a PD peritonitis patient, you may be asked, what is the differential diagnosis of cloudy effluent? All cloudy effluent may not be infective. So one is infectious peritonitis. Second is peritonitis, but there are sterile cultures. So culture negative peritonitis. Then there may be chemical peritonitis. Certain things, for example, long back, there was a stabilizer which was added in icodextrin, which resulted into several episodes of cloudy effluent. People treated it, but then later it was realized it was a chemical peritonitis. So you have to avoid those sensitive things. So adjuvant was removed, or the stabilizers were removed, and people got rid of it. Certain drugs like calcium channel blockers can also sometimes make the PD effluent cloudy. Eosinophilia, for whatever reason, bleeding into the peritoneum. Most of common cause of hemoperitoneum in females is menstrual cycle. So menstruation can lead to hemoperitoneum. Otherwise, trauma, infection itself can lead to hemoperitoneum. Sometimes hemoperitoneum may be initial sign of EPS, encapsulating peritoneal sclerosis. Malignancy, chylous effluent, these all can lead to cloudy effluent. Sometimes dry abdomen. What do you mean by dry abdomen? For example, somebody is night dry. So first time when he drains out after a dry abdomen for 12 hours, it may look cloudy. Okay, so these are certain, and these are all mentioned in books. You can go. I'm just pointing out that these are questions which may be asked. What are definition of refractory peritoneal dialysis, PD peritonitis? So failure of the effluent to clear after 5 days of appropriate. 5 days appropriate antibiotics. Remember that. Right? Recurrent, relapsing, and repeat peritonitis are other different. It's not refractory. Recurrent is after 2 weeks it recurs. Relapsing is relapsing with the same organism, and repeat is anytime it can be repeated. So these are certain terminology which you can go back into the theory book and read it. But refractory PD peritonitis, you should remember 5 days of appropriate antibiotic, after which if patient doesn't respond, that is refractory peritonitis, and most of the time we tend to remove the catheter. So causes of refractory PD peritonitis: multi-drug resistant organism, fungal peritonitis, other microorganisms like tubercular, which we have not addressed, which we have not treated, and secondary causes of peritonitis, for example, perforated gastric or duodenal ulcer associated with pancreatitis, appendicitis, diverticulitis, or pelvic inflammatory disease. So these are certain causes of refractory PD peritonitis. Okay. When do you advise for catheter removal? So obviously refractory peritonitis, not responding. Relapsing peritonitis again and again with the same organism. Relapse means same organism. Fungal peritonitis, you should remove the catheter. And catheter removal may also be considered for repeat peritonitis if it is too frequent. Sometimes with tubercular peritonitis, and sometimes when there is multiple enteric organism in the same PD fluid, which means there is probability of bowel rupture. It may be micro rupture or it may be macro rupture. So in all these conditions, catheter should be removed. And these are certain questions you should remember, which can be asked in case also. And when you are handed over a catheter, a table viva as well. What are the indications of catheter removal? Okay. How do you calculate PD-related peritonitis? Rate of PD. How do you express? You should know how do you express. Somebody may ask when discussing PD peritonitis. It can be expressed in two ways. One is one episode per patient month, or number of episodes per patient year. Okay. We are through 35 minutes, so we have time. Not too many things are left. So let us see how you calculate it. So two ways of expressing PDRP, that is PD-related peritonitis. One is one episode per patient month, and the other is number of episodes per patient year. Okay. How do you calculate one episode per patient month? That means you have to calculate patient month divided by number of peritonitis rates. I'll give you an example. So if I have 10 patients who have been dialyzed for 20 total months. So one patient for 1 month, another patient for 2 months, another patient for 1 month, another patient for 1 month. Total of 10 patients, and total duration of dialysis of these 10 patients is 20 months. You have to calculate that. So you have to make a table, one patient 20 months, one patient 30 months, and total number of patients, and you have to calculate the total number of months. So total number of patients 10, 20 months, and the total peritonitis over this year or last calendar year was 5. So what you have to calculate is total number of patient months. That means 10 multiplied by 20 divided by total number of peritonitis. So 200 divided by 5, which means 40. That means how in this center, there is one episode per 40 patient months. Little complicated, but if you go through this again, you can take a snap of this actually. I don't know if this is shared with you or not. If it is shared, then you don't have to take. But take a snap, you will get it easier to go through it at a later time, maybe tomorrow or after the talk. So this is how you calculate one episode per patient month. And what about episodes per patient year? That means number of here, you have to calculate the peritonitis divided by duration. Here it was duration divided by peritonitis. Remember the difference. So number of peritonitis divided by patient years. The otherwise fundas are same. So you can same thing, same here. 10 patients, 20 months. So you have to calculate individual patients, how many years they were on dialysis. But we have taken the same example. So 10 patients, to a total duration was 20 months. That means 1.6 years. Okay. And 5 PD peritonitis. So peritonitis divided by 10 patients into 1.6 years. That comes 3. That is 3 episodes per patient year. Sometimes people may ask, may not ask, but at least you should know. It is going to help you when you go into practice as well. Okay. So other question is, if you get a patient who is under dialyzed, how are you going to proceed? So this may be a table question. This may be a case question as well. So if a PD patient has a uremic symptoms, how are you, and you find that patient is under dialyzed, how will you proceed? So how you will proceed is a stepwise approach. Number one, as I said, if the patient is not on 24-hour dialysis, the first thing is you put them on 24-hour dialysis. Remember, under dialysis predominantly means there is less solute clearance. It may be associated with less fluid clearance as well, but then less fluid clearance we will address as a fluid overload. Okay, for fluid overload, what you do is a different thing as compared to what you do for a solute clearance. So here we are discussing more under dialysis, that means poor solute clearance. So you increase the duration of dialysis from 12, 14 hours to 24 hours, full day. That is first step. Second step is you increase the volume of dialysis fluid. So you also should remember, unfortunately now it is not available in India. Earlier, the PD bags, the CAPD bags used to come in 2-liter bag as well as 2.5 liters bag. And the cost of both 2 and 2.5 liters was same. So if somebody was on 3 exchange, that means 6 liters a day. If you transfer them into 2.5 liters bag, that means you give 7.5 liters a day, which increases the solute clearance by 25%, right? Without increasing the cost to the patient. So first step was increase the duration to 24 hours. Next step is increase the volume. And the third step, if that doesn't, nowadays 2.5% bags are 2.5 liters bag are not available, then the third step is you increase the volume by increasing the exchange, number of exchange. Somebody who is on 3 exchanges, you may have to ask them to do a 4th exchange. Somebody who is doing APD but they dry, you may ask them to have a last fill to increase the duration. If they are already having 24 hours, you may ask them to add on a daytime exchange. So this is how you improve. And supposing patient is not willing to increase 4 exchanges, then you can always offer them to switch over to hemodialysis. So don't forget that one procedure can be switched. I mean, one can go into second procedure, second can go into first. People have tried hybrid treatment as well, continuing PD for 6 days and 1 day of hemodialysis. So these are certain options how you improve the solute clearance. So let's not go into this part. Since we are talking about PD, you should remember briefly some landmark PD studies. So Canusa, Adimax, Hong Kong trial, etc. are some landmark studies, though very old. You can see Canusa initially was done in 1996, where 680 patients were recruited. Why it is called Canusa? Because it was done in Canada and USA. Very simple, but sometimes examiner may just take a tickle out of it. You should know. Canusa study was done in Canada and USA. That is why it was called Canusa study. And what conclusion was drawn in Canusa 1996 was 0.1 fall in KT over V increased relative risk of death by 6%. Forget about creatinine clearance because nowadays creatinine clearance is not very routine. So 0.1 decrease in KT over V. So from 1.7 it comes down to 1.6. The relative risk of death increases by 6%. That was the conclusion of Canusa study. In 2001 it was reanalyzed, and what was seen, and at that time the recruitment was, the data collected from the previous study was only of 601 patients. So what it showed is peritoneal creatinine clearance had no influence on survival. So what we are talking about is clearance in initial study 0.1. It doesn't attribute the peritoneal clearance. It has no influence on survival. And 250 mils per day increase in urine output reduced the relative risk of death by 36%. So that is how we came to know that residual renal function is very important for survival in PD patients, and same is true for hemodialysis as well. But it was PD which came out with this study where it was documented that just 250 mils per day of urine output can improve the death rate by 36%. That means decreases the death rate by 36%. That was Canusa reanalysis. The other one is Adimax study, which was done in 2002. It had larger number of patients, 965. Why it is called Adimax? Because it studied the different levels of clearance, adequacies, and it was done in Mexico, and that is why it is called Adimax study. Adequacy studied in Mexico. And what it showed is peritoneal creatinine clearance had no influence on survival, and survival is influenced more by age, diabetes, albumin, residual kidney function. And this showed that KT over V more than 1.7, they had a target of 2.1 as well. So KT over V more than 1.7 does not improve the survival. And that is how we landed with this magic figure of 1.7. And then again, reminding you that adequacy of the patient doesn't mean 1.7. There are other factors you have to contribute. The Hong Kong trial was done, which also showed KT over V has no influence. They targeted even less than 1.5 as well, right? But what they found that KT over V less than 1.7 required more erythropoietin, ESAs. So these are some certain landmark solute clearance studies, and there were other fluid and solute clearance EPO study, European study, which showed that peritoneal clearance had no influence. So there are many studies which showed peritoneal clearance doesn't influence survival. Here it showed this was done. This was also done in anuric patients. So what they found that ultrafiltration minimum of 750 milliliters per day is associated with better survival. So when you encounter a patient who is anuric, you should target an ultrafiltration of more than 750 mils by increasing the concentration of bags based on this study. The other was Nicosat 2 study and 1 study. So again, peritoneal clearance, etc. I think just remember these names because you may be asked, name some studies related to peritoneal dialysis. Poor flow, how will you evaluate poor flow? Poor flow, how will you evaluate? So, okay. So poor flow, if somebody has got fluid overload or edema, how will you evaluate? So it depends upon when in peritoneal dialysis you are seeing this. If you are seeing this at initial start of peritoneal dialysis, then there might be many reasons. For example, improper selection of strength of the bags. Number two, it may be leaks as well. So leaks can be extraperitoneal or into the chest as well. Sometimes in initial few days, because there is improper healing of the PD catheter surgery, there might be leaks in subcutaneous plane as well, right? Sometimes there might be communication between pleural and peritoneal space, which I mentioned, hydrothorax. So pleuroperitoneal leak can lead to poor ultrafiltration. How will they manifest? Fluid overload or poor ultrafiltration. Oh, I was talking about poor flow actually. So let me go back first. Okay, let me finish this poor ultrafiltration first, and then I'll go back to poor flow. So poor ultrafiltration in initial stages may be because of leaks, which may be extraperitoneal, which may be into pleural space. Then improper use of selection of bags, lower strength. You may have to increase the strength. How do you determine this? You may, for strength of bags, you can increase the strength and see if the ultrafiltration is improving or not. And for leaks, you may need to do imaging. So apart from clinical examination, you do a clinical examination. If there are disproportionate belly enlargement, that means probably in one area the fluid is getting accumulated in subcutaneous plate. Or if you do a examination of the chest, what we do for pleural effusion, and you find that there is dull node, there might be pleural effusion, which may be a pleuroperitoneal leak, and you do a radiological examination, for example, X-ray, and you document the hydrothorax. And how do you determine pleuroperitoneal leak? If you aspirate the pleural, do a pleural tap, immediately after an exchange, you will find a very high concentration of glucose, similar to the PD dialysate. That itself can satisfy the criteria of pleuroperitoneal leak, and how you manage pleuroperitoneal leak we can discuss if time permits later on. Otherwise, you may have to do a dye study. For example, you can instill radio contrast along with the PD dialysate into the peritoneal cavity, or you can instill radioactive material also, and either you do a CT scan to document the contrast leak into the pleural space or into the extraperitoneal space, even into subcutaneous plane, or if you do a radio pharmaceutical, you can do a imaging into the nuclear scan as well. So nuclear scan can show the nuclear material going into the pleural space or extraperitoneal space. That was about the ultrafiltration part, failure, or the poor ultrafiltration part. Poor flow I meant actually when there is decrease in effluent. So PD fluid, it goes 2 liters but doesn't come out 2 liters, or comes only, or it doesn't come out at all. So what are the reasons of that? That can be discussed in table viva. You may be showed radiological film where PD catheter is present. You have to determine whether it is in pelvis or not. So just migration of catheter tip can migrate upside below the liver or below the spleen or wherever, and that is how the effluent doesn't drain out properly. That is one simple thing. The other cause of poor flow is obstruction. So valve mechanism of the PD catheter, sometimes omental wrap can result into poor flow. So omental wrap works as a valve. So because inflow is good, and that goes because of the pressure height of the PD fluid, PD bag, which is kept at a height on the IV stand. So it goes in. But for outflow, it doesn't have that gravity force. So it doesn't come out, and the omentum wraps around the catheter and closes all the openings of the catheter. So omental wrap is one, migration of the catheter is another. These are some which comes to my mind immediately. Hydrothorax, how to diagnose, we have discussed. How to treat. Treatment is a little difficult. You can give rest to the peritoneum. For example, a month, shift the patient on hemodialysis. Sometimes the shunt may get closed, and if you're lucky, then you can retry the PD, and there may not be a pleuroperitoneal leak. Otherwise, you may have to do a what you call pleurodesis. So pleurodesis can be resorted to close the openings, and that has worked in some patients, but it's an invasive procedure. And then third thing is you can shift the entire patient to hemodialysis. That is another third thing. Fourth is, if hemodialysis is absolutely not possible and other things are not possible, then what you can do is you can do a peritoneal dialysis during daytime itself when the patient is not lying down, because most of the exchange occurs, pleuroperitoneal leak occurs in lying down position. If the patient is standing, it may not cross into the pleural space. That is another option. These are some options how to treat hydrothorax. EPS, encapsulating peritoneal sclerosis. There is huge discussion on encapsulating. Briefly, I will go. Prevalence of EPS is anywhere between 0.4 to 8.9%, and the risk of occurrence is high in long-term peritoneal dialysis, 5 years, 0.6 to 6.6%. I will go fast. EPS risk factors are PD duration. You should remember that is very important, and then recurrent peritonitis. Okay, don't go into details of this. So recurrent peritonitis, and before that, longer the duration of PD, the higher chances of EPS and encapsulating peritoneal sclerosis. How do you diagnose? Both clinical picture and radiological imaging is mandatory. Clinical picture is mostly of intestinal obstruction, and radiologically you can do ultrasound, but CT is more definitive. What you see in CT is, let's go back and okay, here. So you see thickened peritoneal membrane, you see loculated fluid collection, tethered small bowel loops, dilated bowel loops, again peritoneal thickening, loculated, tethering. So these are few words you have to remember: peritoneal membrane thickness, bowel tethering, loculated collection of bowels. So these are certain things which you can say when discussion of EPS comes in. Management is mostly supportive, aggressive nutritional support, shift on to hemodialysis. Sometimes antifibrotic agents like tamoxifen, immunosuppressive like steroids have been tried. And if the surgeon is very good, they can do enterolysis. In Japan, many surgeons do it routinely. Okay, so that was about case. Now, quickly, we will in another maybe 10 minutes, I have 10 minutes time in 1 hour, we will go through certain table vivas. So APD machine, this is how APD machine, this is the most advanced APD machine. There are older version as well. So this is what is APD machine looks like. So when you get an APD machine, they may ask you, how do you program it? So how do you program it is what you feed into this so-called computerized system is total volume of exchange. So APD bags come in 5 liters. It doesn't come in 2 liters. Okay, you have to remember. So it has to be in multiplication of 5. So 10 liters or 15 liters. That is what we usually use. Okay, and then first is volume. Number 2 is duration of APD. Okay, so duration means how much time you want patient to be hooked to APD machine. So obviously it is done in the night time predominantly. So you ask what time, how much time patient sleeps, but it has to be more than 10 hours, 10 to 12 hours, maybe 14 hours if you want more clearance, etc. So 10, 12 hours you feed it to. So volume, duration of treatment, and what do last fill, you want patient to come out with the belly full of dialysate for the daytime or not, last fill. All these three, when you put into the system, it will calculate in number of exchanges. So another is number of exchange you have to fill in. It will calculate the dwell time on its own. Something you should remember, newer machine has got share source. So it is linked to the nephrologist's software. So even if patient doesn't come to you, you can get the daily data from your computer using that software because it is linked to without a wireless link is there. Okay, so people may ask, somebody may ask, what is share source? That is what it is because the data is linked to nephrologist software. So this is APD cassette. I've seen patients not able to answer what this is. This is how it looks like, APD cassette. This is must to be, if you want to put in APD, it fits here. APD cassette fits here. Okay, there are 5 ports. One of the port goes into the drain bag. You have to remember that. Okay, one of the port goes into drain bag. One goes hooked into the, rather 6 ports. So one goes into the patient. One goes into the drain bag, and there are 4 ports which are connected to the PD bag. So at one time, you cannot connect more than 20 liters. Okay, so these 4 are the bag, PD bags. One is for patient, one is for drain bag. Okay, there are 6. Plus, this red is what is the port is to be connected to the bag which is on the warmer. So remember this is the warmer of the APD machine. So if you have 3 bags, 1 bag is going to lie on the warmer. The other 2 bags are to be connected and to be kept on the floor. Patient gets PD fluid from this bag only. So once this is empty, PD fluid will get transferred from the floor bag into this bag so that it is heated up to the optimal temperature. And that is how this bag will be connected with the red port. So this red port. 3 other ports, these are other ports. Fine. What PD catheter can be there on the table, and you may be asked to pick up the PD catheter. It can be acute stiff PD catheter, which you must have seen. You should see that, and it looks like something like this: straight PD catheter. Okay, straight PD catheter, and it is stiff. And usually it is introduced using a Seldinger technique with a trocar cannula. So acute stiff catheter. Rest all are soft catheter, which is made up of silicone, which may be cuffed, which may not be cuffed. There might be single cuffed, there might be double cuffed. You should remember the name Tenkov catheter, which is very important. There are other Tenkov catheter may be straight, it may be swan neck, this swan neck. There might be coiled catheter. And the idea of using swan neck coiled catheter is so that catheter doesn't migrate and doesn't lead to omental wrap or blocking of the openings, right? These are different kinds of catheters. So you should read about different types of catheters. However, whatever type of catheter is used, the outcome is not different. So outcome, whether it is related to peritonitis or survival of the catheter, etc., is not different whether you use straight, cuffed, coiled or swan neck catheters. Some have seen people have never seen Minicaps. So Minicaps are caps which are used to cap the PD catheter. Okay, so these are Minicaps. Titanium adapters. So these are adapters which are put into the PD catheters, Tenkov catheters, to which the transfer set and the connection of the PD is made. This is made up of titanium. The question many times radiologists also ask is, when the patient has to go to MRI, this being metal, whether they can go to MRI or not. They can. Titanium is MRI compatible. So you should remember titanium is not a contraindication for MRI. This is the transfer set. So this transfer set is attached to the PD catheter, and then to this transfer set is attached the PD bags. I think I am done here, and I've tried to finish it off in an hour's time. Many things I may not have picked in, and because of the time constraints, many things I may not be complete because it was totally an informal talk. It was not a lecture. It was prepared in haste in just 4 days time, but I'll be happy to answer your questions related to your PD, peritoneal dialysis, and your practical exam. You can unmute yourself and ask questions. So I'm happy for appreciation, but I'll be happier if you clear your doubts right now. Otherwise, Dr. Kher is not going to leave me behind. So I'll wait for 5 minutes. If anyone has any doubt, we can clarify it. Otherwise, I believe that you all have understood. Okay, cassette once again. So cassette is kind of a blue colored. Usually it is blue colored only. I've seen blue colored only. Is the tubing system which attaches the machine to the patient and to the drain bag. So what happens is, one by one, I'll answer the question. So there are one tube will go to the patient, which will be connected to the peritoneal dialysis catheter. The other extreme connection will go into the PD drain bag, because the spent dialysate, where is it going to go? It is going to go into the drain bag, right? Apart from that, there are 4 ports which can be connected individually to 4 bags. At a time, you can connect it to 4 5-liter bags. See, APD is done at night predominantly, so patient doesn't get up to connect or disconnect the system. You have to connect it at the time of sleep. So if you decide that patient goes into 10-liter exchange, that means 2 bags of PD fluid, one will be kept on the warmer, the other will be kept on the floor. And two of these bag ports will be connected into these two bags. The other two port can be tied as a knot because they are not going to do anything, right? If there are 3 bags, you use 3 bags, 3 ports. If there are 4 bags, you use all the 4 ports. So I think that is very simple. I mean, you will not be confused about that, I'm sure. They won't be asking that many questions as well. So how frequently transfer set to be changed? It depends, usually 4 to 6 months. Okay, usual practice is 4 to 6 months, transfer set should be changed. The other question is indication of choosing aminoglycoside over other gram-negative organism. So indication is usually most of the gram-negative bugs are not resistant to aminoglycoside. But then since aminoglycoside can decrease the residual renal function, which is very important in our PD patients, so we tend not to use aminoglycoside unless the patient is anuric. And anuria is defined by urine output less than 100 ml per day. So apart from usually sensitivity, I mean sensitive aminoglycoside sensitive bug, it is very cheap also. So that is also another reason of using aminoglycosides. Then comes another question. It has 4.5% bags not available. Then how do you check for peritoneal ultrafiltration? So ultrafiltration failure can be checked with 2.5% as well. But the if you do not get, for example, 200 ml, the standardization was with 4.5%. So if there is poor ultrafiltration, one of the reasons of poor ultrafiltration may be ultrafiltration failure. Other reasons may be, for example, as I said, leak, or catheter migration, or inappropriate use of the concentration of bags. All these are causes of poor ultrafiltration. Ultrafiltration failure is a specific terminology of one of the cause of poor ultrafiltration. So what you can do is use a 2.5% bags, and if that results in 4 hours, it results in less than 200 ml of ultrafiltration, it is possible ultrafiltration failure. Okay. An ideal method of fluid culture for PD peritonitis site and transfer media. Okay, so this is an important question. So most of us should know how to collect. So ideal method is when the patient is at home, because obviously PD is done at home, and he realizes that there is a possibility of cloudy effluent or symptoms related to PD peritonitis. Ideally speaking, they should be given 2 blood culture bottles. The shelf life of blood culture bottles is about a year, after which it has to be replaced. And they have to draw the samples. They should be trained how to draw the samples out of the bag, inoculate the blood culture, and come as quickly as possible to the PD center where rest of the management can be done. Right? So most of the time it is not practical in India. So what they do is when they come into the emergency or into the clinic, what we do is we collect the bag, the entire bag. The entire bag is sent to the microbiology department, where they collect a sample and send it to the biochemistry department for TLC, DLC, etc. Send another sample for gram staining and whatever ZN stain if you want, or fungal stain, KOH stain you want, and draw about 100 ml of 250 ml aliquots. Centrifuge them. After centrifugation, they collect the deposits and then plate them into the blood culture media. That is the ideal way of doing the culture. And that gives the positivity rate very high as compared to just inoculating the fluid. So that is the ideal way. Okay. Can meropenem and vancomycin instilled simultaneously into PD fluid? It can be, but you should use a separate syringe, because at times we have seen vancomycin can precipitate the other antibiotic, or the antibiotic may become like a precipitate. So you can use in the same bag, but with a different syringe, you can use it. Okay, not with the same syringe. In calculating KT over V, do we take average of all bag urea concentration for DB? Yes. So the entire dialysate has to be emptied into a container, for example, a bucket or whatever, mix it thoroughly, and then take the sample for urea. You cannot take from one bag because the bags may differ. You're absolutely right. So if patient presents with peritonitis and in sepsis, and we are giving both IV and intraperitoneal antibiotics, do antibiotics should be same or can be used different? So there is no reason to use both route of antibiotic. If the patient is sick, then you can straight away go to IV antibiotics. You do not have to give antibiotics both intraperitoneal as well as intravenous. So choose one way. And yes, both the antibiotics can be given, same antibiotics can be given through both the routes. Most of them. Some of the antibiotics cannot be given intraperitoneal, but most of the antibiotics can be. So calculation of OCG double mini PET. What is OCG? What is this calculation of? Can you tell me? I'm not able to get this question. OCG double mini PET. What is double mini PET? I'm not sure about this. We'll take this later on. Aminoglycosides have post-antibiotic effect. Is it helpful? Yes, it is. It is helpful. Is there any shelf life of in situ PD catheter? Shelf life of in situ PD catheter? No, there is no such shelf life. PD catheter can remain for years. We have had patients beyond 5 years, 8 years, 9 years as well. But recurrent peritonitis can impair the PD catheter functioning at times. It can damage the PD catheter. Wear and tear may be there. So all these are, but there is no shelf life as such. So I'm not able to answer this one question about OCG double mini PET. I would request you to probably go back into the textbooks and find this out. I'm not able to answer this question. I think rest I have already tried to answer the questions. Okay. Okay, Puneet, shall we stop?
Okay, sir. Yeah. Thank you so much, sir. If you have any more questions, or we can thank sir.
All the best to all the participants for your exam. Whether you get a PD case, it is immaterial, but all the best to all of you. I wish all of you best of luck, and try work whatever time you have. Try hard to get a very good examination.
Thank you, sir. That is what is the most needed.
Sure.
Thank you for sparing your time in such a short notice, sir. Thank you again.
Okay. Okay. Bye.
Thanks, sir.
Bye.